Thanks so much for having me today. It's great to be with you and to have a little bit of time to chat with you about this, what I think is a very hot topic. And I was just reading again this morning, Novo Nordisk, which makes one of these medications, is just driving the economy in Europe right now. So it's the largest company and biggest seller. So we can't ignore these things that are happening around us. And I think too many times in our space, we think about, there's medicine and there's lifestyle, and those two paths should not cross. Don't do that medication, don't do that. You can do it with exercise. And the reality is that we don't do that with any other health condition. Why would we do that with obesity? We don't do that with hypertension, hyperlipidemia, or anything else. Let's make sure we have a space for physical activity as opposed to a them versus us. So just one quick disclosure that doesn't have, that won't influence what I have to say today. But if we think about the condition of obesity, and obesity is now considered a disease by the AMA and many other leading medical organizations. We can take this kind of simple approach where we think about lifestyle as an important factor, and if we could simply change our eating behavior, our energy intake, change our activity, promote moderate to vigorous physical activity, that's going to change body weight, that's going to change body composition, adiposity, lean tissue, and the like. However, and I will not go through this, and this is not comprehensive, but just overlaying these factors onto it, it says that it's not as simple as people should just eat less, be more active, and body composition is going to happen, body weight's going to go down, obesity is going to be treated. There's a lot of intermediaries that get affected when you start to change lifestyle. In addition, we sometimes forget, and maybe sometimes don't know, that when you modify physical activity, for some people that's going to cause them not to feel very hungry. For other people, they're going to want to eat everything in sight. That these two things are not independent, that they are intertwined. And you all know people, if you go out and exercise with them, as soon as they're done, they're like, where's the food? Yeah, and I know for me, when I'm done exercising for a few hours, I'm like, give me some water and that's about it. I don't want to eat anything. And that could be a really important response. So it's not as simple as telling people, eat less, exercise more, sit less, just get up and move, and we're going to be able to regulate, body weight the way we think we can. And it's evolved over time. So it's complex, and we need to understand it, but we also need to understand the inter-individual response to these types of things. And if you lay on top of that a bunch of other factors, such as genetics, environment, and now medical treatments for obesity, but also medical treatments for many other things, you'll understand that it's just not as simple as burn more energy, eat less energy, and obesity is going to be taken care of. And obesity is just manifested. I want to make sure we emphasize this. The disease of obesity is just manifested in excess weight and adiposity. All right, that's how it manifests itself. But its real condition is affecting many, many other organ systems in the body. So, as we think about treatment options, we basically currently have three: lifestyle, pharmacotherapy, and what we'll call metabolic and bariatric surgery. All three of these can be very effective for various reasons and for different people. But the thing that's getting the most play right now are these, what we'll call anti-obesity medications. They're what we now are calling second and third generation medications. Some people call them GLP-1 therapy. Some people call them incretin-based hormone agonists. Some people call them nutrient-stimulated hormone-based therapies. You're going to hear all the things. But in the real world, people refer to it as the Ozempic kind of era or the GLP-1 era. And in essence, the newest medications are based on GLP-1 but are not solely GLP-1 based. So in the fitness field, and Neil heard me say this at the Health Fitness Summit a few months ago. In the fitness field, there's a contingency of people in our profession, and you may be one, and that's fine, who feel like, if people would just exercise more, we wouldn't have an obesity problem. If people with obesity would just exercise more, they would lose all the weight, be at perfect body weight, perfect BMI, perfect adiposity, perfect lean tissue, perfect everything. All right? Well, let's take an example that hopefully will hit home a little bit. This is Kelvin Kimpton. In 2023 in October, he set the world record for the marathon, which we just learned about, where that term came from, in Chicago at 2 hours and 35 seconds. Unfortunately, a couple months ago in his home of Kenya, he was tragically killed in an automobile accident. But in October, he set the world record. So, how many of you in the audience could run a 2 hour, 35-second marathon? All right. How many of you in the audience, if you could train like this young man, had the time to train, had the nutritional support, had the environment around him, around you that he had, with all the trainers, everything, and could put the time in, how many of you could run a 2 hour and 35-second marathon? Wait a minute, why not? Why can't, if you had everything that he has, why cannot you run a 2 hour and 35-second marathon? You should be able to, if it's all about training and if it's all about exercise. Well, there's a training element that goes into it, right? You need to be able to train the right way. That's something that, we have to think about across the board. There's an environment. You got to have, enough time. You need to have the right people. You need to have the right support. You can't have things distracting you if you're going to run a 2 hour and 35-second marathon. But you know what else you need if you're going to run a 2 hour and 35-second marathon? You need the right biology, the right physiology, and the right genetics. Two people training exactly the same way, one might run a 2 hour and 35-second marathon, one might run it in 2 hours and 30 minutes. There's a component there that matters. So when you start to think about these things, response to exercise, response to lifestyle is not just about doing the lifestyle behavior. There's other factors that come into play. And so when we think about obesity as a disease, both the causes and the treatments of that, these factors come into play as well. And these obesity medications, all right, are trying to address two things that make a big difference in how people respond. One is, there are people who are biologically, physiologically, and genetically compromised a bit when it comes to how they regulate their body weight. And we're learning this more and more. And by helping people to address those concerns, which is what these current medications are attempting to do, it helps the behaviors to be easier to do. The one thing that we're hearing in the space right now, and these medications are based upon increasing satiety, decreasing hunger, slowing down the digestive process. People are saying for the first time, it's minimizing what they call food noise. They aren't thinking about food all the time. They're thinking like, I'm not hungry right now. I don't need to eat. Now, needless to say, these medications are probably being misused by people who they're not intended for. But it's slowing down the food noise for people. And because of that, it's helping them to change their behavior. But if it's thinking about taking that marathoner, and if I could give you a medication that would even the playing field for you, biologically, physiologically, and genetically, if I could even the playing field for you, such as the person that holds the world record in the marathon, and put you on the same playing field as that person, when you train and are in that environment, you could run a 2 hour and 35-second marathon. So what these medications are doing and are attempting to do is to even the playing field for individuals who have a difficult time due to their biology, physiology, and genetic makeup that make it more difficult. Needless to say, people make decisions to eat. We all do. People make decisions not to get up and move. We all do. But when people do, not everybody gets the same response. And that's what these medications are trying to do. So it can't be just a lifestyle versus a medication kind of world. And if you think about what's in the insert of these medications, in the packet, it doesn't say lifestyle should be an adjunct to these medications. It says that these medications should be used as an adjunct to lifestyle, that the foundation is still lifestyle and physical activity and eating well, and these should be added on. We need to help to change the paradigm of the way the world is seeing these things, that lifestyle is still important. So a little bit about the medications, and I don't have time to give you the comprehensive view, but there's a lot in the literature and about it. I'll point you to a couple of references on it. For a long time, up until about 2005-ish, 2009, something like that, we had what we called first-generation medications. These medications were mostly built upon this idea that if we could change the biochemical makeup of what's going on in the brain, we could change people's hunger and satiety responses. And some of those met with what I'll call modest success, but most of them came and went on the market. Many of them started to have side effects, and so they got pulled. Some of them, for lack of long-term efficacy, they got pulled. But these were modestly effective. Then came along these second-generation medications, which started for the first time to show much greater effectiveness. But these medications were primarily, the ones that we're seeing now, primarily started off in the diabetes space. They actually started off to help treat diabetes, and then weight loss was a secondary to that. And the big medication that came out at that time was the drug called liraglutide. You might know it as Saxenda. You might have heard this on TV as Saxenda. And now we're at third-generation medications. And these third-generation medications are things like semaglutide, tirzepatide. These are the backbones of these medications. And these are the liraglutide, semaglutide, and tirzepatide are all the GLP-1-based medications. So what are these second and third generation medications? And then I'll get into what they, how effective they've been. Second generation was the liraglutide. It's a single-acting GLP-1 receptor agonist, which means it's basically blocking the receptor so that it's helping to control appetite, hunger response, and it's also slowing gastric emptying. Those are the two big mechanisms of action. Third generation have kind of changed the GLP-1 receptor agonist makeup. They're much more effective. Semaglutide was the first one in that space. Tirzepatide has since come on, and that's a dual acting. So it's taken tirzepatide, it's added GLP-1 to GIP, and it's showing a little bit better effectiveness. And now we have in phase 2 and now starting phase 3 clinical trials, this drug called retatrutide. I always stumble over that. But that is now, it's not approved by the FDA for use at this point, but is a triple acting. So it's adding glucagon receptor agonist, and they're hoping that that's going to show even better response in terms of how the drugs are acting. So these are evolving very, very quickly, but it takes many, many years for them to go through the process. So right now we have two backbone medications, semaglutide and tirzepatide, which are these current second or third generations that are probably the most effective. Why is this important? Well, if you go on Google and just put in something around anti-obesity medications, you're going to get 63 million hits. And that was months ago when I did that. These are not going away. In 2022, there were 3.6 million prescriptions. The data are not in yet for 2023, but it was anticipated that there would be a 35% increase, and I think we've blown past that. In 2024, it's just off the charts. In fact, it's very difficult right now to get semaglutide. Some people call it semaglutide or tirzepatide. They're in some shortages. But it suggests that there's going to be over 60% of people with type 2 diabetes that are going to be on one of these types of medications due to their effectiveness. The one thing I want to point out to all of you as exercise professionals, and this is a very controversial area right now. The only official approved medications are semaglutide, which is produced by Novo Nordisk, and tirzepatide, which is manufactured and produced by Eli Lilly. The FDA does not approve the use of either of those medications when made by a compounding pharmacy. They are not the exact molecular makeup. And there are many compounding pharmacies out that you hear them on the radio and TV all the time. Call us and we'll give you a medication. Those are not approved, and in fact, the FDA has come out against those at this point because they cannot approve them at this point. So, if you work at a gym or a fitness center and you want to partner with a compounding pharmacy, I would be very cautious, because if something happens, that is not an approved medication. The only ones that are by the ones that are made by the manufacturers. So, how effective are these medications? And I'll speak from a weight loss perspective, knowing that there's a lot of other downstream effects and more data are coming out, and I'll say something on that at the end. Semaglutide is a very effective medication. And what you're seeing here, I don't know if this pointer doesn't work. Let me see if I can get this to work. Probably not. But up in the corner, semaglutide, when you look at this trial, one of the first trials, it demonstrated a 16% weight change from baseline. To put that in perspective, lifestyle programs at best can give you 10% on average. On average, in this study, it was 16% compared to a placebo-controlled condition, which was 5.7%. So the difference in weight loss was of 10 percentage points when it came to this medication. So much more effective than what we've seen out in the literature up until now. When you compare the earlier generation, liraglutide versus semaglutide, you can see that semaglutide in this particular study was 15.8% compared to liraglutide, which was about 6.4%, compared to placebo, which was about 1.9%. So you can see that this second or third generation medication, semaglutide, seems to be showing much greater effectiveness than placebo control and much better effectiveness than the the liraglutide, which was the early GLP-1 receptor agonist. What's very important about these medications, and this is a study that was published not that long ago, was a Step 4 trial, they called it, where they, for 20 weeks, had people on semaglutide, and then after 20 weeks, they re-randomized people to continue the semaglutide or to get a placebo control. So basically got removed from the medication. And what you can see after a period of from week 20 to week 68, those who stayed on the medication continued to have weight loss. Those who were on a placebo control and came off the medication started to show a rapid regain of their body weight. So a question that comes up all the time is, so once people lose weight, can they come off of the medications? And the answer to that is probably not the way we do things right now. It'd be like saying, once a person loses weight, can they stop eating healthy and stop exercising? Well, you know what's going to happen when that happens. They're going to gain weight back. And these medications are exactly the same. We do not, in hypertension research or in hypertension clinical care, say, if you have hypertension and your blood pressure gets under control with medication, you can stop it. We don't do that with other types of treatments, medical treatments. We continue those treatments and only come off of them if it's absolutely required and appropriate medically. So this idea that we should be putting people on these medications and then taking them off once they lose weight doesn't make sense on a medical way of thinking about it. And that's where activity and lifestyle come in. If we can help people to adopt a healthier lifestyle, maybe we can reduce the frequency of these medications. Maybe we can reduce the dose of the medication. Maybe people can come off the medications, but we need a strong lifestyle backbone to what we're doing here. So tirzepatide is the most recent one that was approved. It was approved for obesity treatment in November of this past year under the name Zepbound. So we now have a medication called Zepbound. And by the way, semaglutide is approved under two names. One is Ozempic. That is a medication for diabetes. Wegovy is the medication semaglutide for obesity treatment. Okay? So when we're talking about obesity, we're talking about two medications, Wegovy and Zepbound are the two. And Zepbound is the tirzepatide. And this just shows you on a dose response basis when they did the trials that you can get about 20% or 21% weight loss in tirzepatide. With semaglutide, you were getting about a 16-ish% weight loss. So it's a little bit better in terms of weight loss, and it's probably due to the fact it's a dual-acting medication as opposed to a single-acting medication. Retatrutide, which is the one that is currently entering phase 3 trials right now, you can see at the bottom, over a 48-week period of time, this is demonstrating at least, and this is data from a phase 2 trial, 24%. So when you add, a third component, it's a triple-acting medication, it's gone to 24% weight loss. So the weight losses are much better. And to put that in perspective, for a person who is 200 pounds, 10% weight loss would be 20 pounds. 20% weight loss would be 40 pounds. So just kind of putting that in perspective in terms of how much weight we're talking about. So how have these things changed over time? And this just shows you how these have become more effective. You can see on the far left that lifestyle approaches to weight loss on average give you about 5 to 10% weight loss. Now, in our trials, we get to 10%, and we have people about 25, 30% who lose much more than that. So there are high responders to this, but there's also low responders. But you can see over the course of time how these medications have changed in what they do and what their targets are, that they're becoming much more effective when it comes to if weight is your answer. The one thing I want to point out to you is I think so many times we focus on weight as the outcome. The issue here, though, is what we're finding with these GLP-1 receptor agonist medications, and the trials are being done and being published. For example, the SELECT trial demonstrated that individuals who were on these medications had far less greater cardiovascular events than individuals who were not on the medications. So we're seeing this for kidney health, we're seeing this for cardiovascular health, we're seeing it across the board that these medications, probably through their effects on adiposity and their effects on body weight, are having major, major impacts across major body systems, not just cosmetically a person losing weight. So that's really important for us to keep in mind. However, when you look at bariatric surgery, that comparison, these medications are becoming closer and closer to what bariatric surgery can achieve. This one's a little, I don't know how well you can see that, but this slide is a slide that we put together for a paper that I did with a colleague of mine, Tom Wadden, who's at the University of Pennsylvania. And we did a paper on lifestyle considerations within the context of these medications. And what we're just showing you here is on the far left, this is the diabetes prevention program and the look-ahead studies. And each of the colors, the light color is how many people made 5% weight loss, then 10%, 15, and then 20. And you can see in the diabetes prevention and look-ahead trials, which were the big lifestyle programs, there are not a lot of individuals making 10% weight loss or greater. But as you start to then look across these different medications, and these are two semaglutide and one tirzepatide study, that more and more individuals are making better weight losses. And a lot of folks think that the 5% weight loss is, if we can at least get people to 5% weight loss, that's great. You can see in the most current trials, it's pushing 90% of people with these medications. And I can tell you, I've seen data recently on the retatrutide study that 100% of the people that got that medication made 5% weight loss or more. So they're becoming more and more effective if you count it on weight loss. So what do we know about these medications, and what can I tell you about exercise? Well, we know that they're very good for weight control. We know that they're going to help us with weight loss. We know that they help better control type 2 diabetes. I put up cardiometabolic risk, but it's, cardiometabolic events. There's multiple benefits. And we know that it'll reduce adiposity. The problem with many of these trials is that they don't include measures of body composition. If they do use measures of body composition, they don't use very good methods. And if they do report on them, you got to dig into the back supplemental materials and try to do your own math to figure out how much the body composition is actually changing. So, however, one downside potentially of these is based upon what we can determine from the data available in these trials, is that the lean mass is reducing by about 25 to 40%. And that the lean mass loss with tirzepatide is around the 25 to 30% mark. With semaglutide, we're looking somewhere between 30 and 40%, depending on the study. And again, most of the studies haven't been reporting body composition, and if they have, you've got to do the math to figure out what that percent change actually is. So what you hear a lot about is this lean mass loss. Look at all the lean mass loss that's happening, and this is where exercise comes in. And what we need to do is just have people do a bunch of weight training, and that's going to prevent the lean mass loss. And what you also hear people say is, they don't say lean mass loss, they say, look at all the muscle that these folks are losing. There are 0 studies published on these medications that have directly measured muscle. Lean mass is not muscle. Lean mass is muscle, organ tissue, connective tissue, bone, you name it. None of the studies have measured muscle mass. I'll stand here today and tell you, starting next week, we're starting a trial that will be measuring muscle mass. But right now, we don't know if it's muscle, we don't know if it's cardiac tissue, we don't know if it's liver, we don't know what it is at this point. So we have to be careful about that assumption. So what are the implications for our approaches to obesity treatment? Well, we published a paper in the Translational Journal of the ACSM not that long ago, earlier this year. And we indicated ourselves that there are 3 pathways or pillars that you can use: lifestyle, pharmacotherapy, or metabolic surgery. However, the choice of that is made by the patient along with their healthcare provider. Which one do you go for, and which one's best for that patient? And there has to be a shared decision-making on that part. But what I want to point out to you is that lifestyle is critical in terms of this. And lifestyle isn't just physical activity. It's behavioral counseling, it's nutrition, dietary counseling, and these things interact. In addition, even with pharmacotherapy, lifestyle has to be a component. With metabolic and bariatric surgery, pharmacotherapy may be a component, but lifestyle is definitely a component as well. And when you have a person doing lifestyle, we need to keep our options open, depending on how they're responding, that pharmacotherapy may need to come on the table, and or bariatric metabolic surgery might need to come back on the table. That these things are not independent of one another, and they all interact, but at the core of it all, every one of those arrows points to lifestyle. And when you come out of lifestyle, that arrow points to physical activity, healthy eating, and behavior. So it's part of the discussion, and it's part of the treatment plan. If you want to learn more about how many of these medications work, I would encourage you to go to this publication that's openly available in Current Obesity Reports. This is the paper that Dr. Wadden and I and others wrote, and you can find it available. It's an extensive discussion about this, as well as how lifestyle fits. So what are these implications? What are they for physical activity? So again, point this out to you, that we're concerned about the lean mass loss, but we don't know much about the muscle change. And that's where my perspective comes in on where this all fits. So, lean mass is not muscle. Muscle is part of lean mass, but all of lean mass is not muscle. We have to remember that. Also, I think that we have been too concerned about volume of lean tissue as opposed to quality of lean tissue. And I say that, I'll show you some data here. If you look at a patient with obesity that may weigh, let's just take an extreme, 300 pounds, and you put them against a person who weighs 150. The person with 300 pounds actually has more lean mass and more muscle mass than that person that weighs 150 pounds. They already have much more muscle, much more lean. The difference is the quality of that tissue isn't as good. And we've been too worried, I think, in my mind, about the volume as opposed to the quality. So let me show you some data that supports that. This is a study we published a long time ago, but it was very low calorie, very low energy diets, like liquid diets, 500 to 800 calories a day, and we were the first group to actually add exercise to this. So we had people go into one of four conditions. They got the diet alone, they got that same diet, plus supervised endurance exercise training 4 days a week that progressed upwards of 70 minutes, that progressed up to at least 80% of VO2 max. We also had a group that got that same diet and got resistance training. They came in also 4 days a week, 8 exercises, 3 sets, up to 8 repetitions that progressed upwards of 80% of 1 RM max. So very strenuous resistance training program. And then we got one group that got that same diet and got both. What did we find in this study? Well, and this is, a lot of weight loss. This is a lot of calorie restriction, but these medications are causing a lot of calorie restriction at this point in time, which is causing these big weight losses. Across all of those conditions, people lost weight. And they all lost the same amount of weight, and that adding more exercise to it, when you get to a certain calorie level, adding more exercise does not cause more weight loss. It doesn't, you say, well, why? Well, there's a lot of compensation going on. But adding more exercise to these low-energy diets didn't add more weight loss. But is that really the whole story? Probably not. So we looked at fat mass, and all the groups lost the same amount of fat mass. When the calorie levels get low, the body helps to make up for that, and everybody lost the same amount of weight, and everybody lost the same amount of adipose tissue. We also looked at changes in lean mass. And guess what? Even with the exercise and heavy resistance exercise, lean mass was lost at the same magnitude as the people that were on the diet. That the exercise didn't help to curtail that much at all. Okay. So what does this all mean? Well, again, lean mass is not muscle mass, and volume does not equal quality. So, we actually did strength measures on these folks, and we computed this, what we call strength index, across the different exercises. And what I want you to pay attention to is the 2 bars on the right, the 2 green bars on the right. Those 2 showed significant increases in strength. And those that showed significant increases in strength were doing resistance exercise, even though they lost the same amount of lean mass as the people who were not doing any exercise at all. When it came to cardiorespiratory fitness, there was a significant increase in cardiorespiratory fitness in people who were doing endurance exercise training, even though they lost the same amount of lean mass as the individuals who were doing no exercise at all. So even in the presence of a loss of volume, exercise changed quality and physiological response as we would expect it to do that. And what we did in this study, and it's published, and I just didn't bring a slide to show it, is in a small subsample of people, we also did muscle biopsies of the vastus lateralis. And what we found is even in the presence of loss of lean mass and overall loss of that lean tissue, the cross-sectional area of the vastus lateralis improved. And that's reflected by the strength improvements that we observed in the muscle. So my argument to all of you is, when we think about weight loss, yes, we should be thinking about body composition, but let's be careful about overreacting when lean body mass goes down in the presence of exercise. Because if that person's getting stronger, they're able to lift more weights, their cardiorespiratory fitness is improving, that tells me that the body's responding and that loss of lean tissue is actually not problematic. That loss of potential muscle mass is not problematic. It's a natural adaptation, and exercise can still cause the response that we're hoping for. And so I think we need to move beyond just body composition and have muscle quality. In many clinical settings, we can't measure muscle quality or measure it cost effectively, but you can ask people to give you a grip strength test. You can do and see how see how much weight they can lift with their legs. You can get a cardiorespiratory fitness test. You can do functional tests that would reflect that this person is actually getting healthier from a functional perspective and a muscle perspective, even though lean mass might be going down. And so we've been talking a lot about this, and we published this paper that has that same kind of example in it in the journal Obesity last fall. And this is also available online if you want to go search it. And it was a perspective paper. And I'll show you, this is what the figure looks like that's in there, but it's a framework. And I'll show you that we have these incretin-based, GLP-1-based, Nushi-based therapies that we know affect body composition and weight and reduce adiposity. We know that if we can reduce adiposity, that's going to have some effect on improving health and well-being. However, we also are observing that there's some loss of lean mass along with these medications. When we think about physical activity, and there's very few studies of physical activity out there, and I'll show you one here shortly, we also know that by itself can affect adiposity. We do know that it can affect muscle and lean tissue, and that can maybe reduce sarcopenic-related conditions that it can improve health. But all that's working through body composition and weight. But you and I both know that physical activity can affect muscle quality and function. We also know that there are health benefits of physical activity that don't work through body weight, adiposity, and lean body mass. And that's important for us. And so within the context of obesity treatment, if we're thinking about holistic health and well-being of a patient, weight loss is just one component, and doing something around muscle quality and function is just one component of why physical activity is really important for these individuals. Just a quick show of that is that we published a study that showed that even in the context of weight loss, the only way we improve the physiology of the heart tissue was through exercise in the context of weight loss, and we showed that in 2 different studies. So I got about 3 minutes left, and I wanted to share with you a couple final thoughts. This is the only exercise study that's been published that has combined exercise with one of these GLP-1 receptor agonists, and it was done in liraglutide. And no studies, again, have looked at muscle. And what they did in this study, just to orient you, is for the first 8 weeks of the study, they gave people a low-energy diet. Individuals all got a low-energy diet with no medication. So they already had lost 14 kilograms by the time they got to what we call 0. Once they lost that, they were then randomized to a placebo medication, exercise plus placebo, liraglutide with no exercise, and liraglutide plus exercise. And you can see that the combination of both liraglutide and exercise seems to do better than most of the other conditions when it comes to weight. And if you look at the body composition, it does do a little bit better when it comes to the body composition. But this is the only study out there published on exercise, and it didn't start exercise right at the beginning. The study I mentioned we're kicking off right now starts exercise right at the beginning, and it's going to compare cardiovascular endurance training with resistance training in a supervised way to see what actually happens. So some implications. Understand that exercise is really important. Physical activity is really important. But what I point out to you is there are people, individuals, patients with obesity that have major limitations around their movement. And sometimes the first thing is not to throw them into a gym setting and say, start doing resistance training, start walking 3 miles a day. Sometimes we just need to get them functional so that they can start to do those activities. And so we have to think about this progression. We would, when we think about cardiac rehabilitation, we can use the same types of models when it comes to obesity treatment and how physical activity fits. So we are in a new era, and I'll finish in about a minute. So I'm going to run 30 seconds over. Recommend exercise, but not just for weight loss. And when we think about that, we published this in the few papers that we've published on this on our perspectives. It's about holistic care of that patient with obesity, not just about the weight loss. And physical activity is important in that whole holistic care of patients. However, we've done a survey of patients who have gotten these GLP-1 medications. We did a survey of them. And what we found was the vast majority of them who are given these medications are not being physically active enough, and the vast majority of them are not adopting resistance training. So we have work to do here. We have to work with our clinician colleagues to build an activity program into their clinical care. We also talk to the patients, and they're afraid to exercise. Some of them are afraid, but some of them don't like the environment in which we've created for them to exercise. There's a lot of stigma that goes with it. They don't like the way they look, they don't like the way they feel, they don't like the way they're being treated, and what they've told us is that they don't like the way when they go to the gym, the staff there think that they're like everybody else. And that causes them to not come back. We've got to rethink how we approach exercise if we're going to help people to adopt exercise. So, for us to do this, and some concluding statements, we need systems and approaches in place. We need appropriate systems and approaches in place. We need health providers who are prescribing these AOMs to consider activity within the comprehensive care of these patients. Oops, I don't know why it went upwards. We need healthcare payers to help to facilitate appropriate opportunities to build physical activity for these individuals with access to the appropriate exercise professionals who are well trained to work with patients with the disease of obesity, which is different than working with a person without the disease of obesity. This includes making sure we have equitable and inclusive access to these opportunities for all patients with obesity. So as we also think about this, we need professional organizations, colleges, universities to make sure that they're getting behind this and providing the appropriate training. And very importantly, we need the pharma companies who are making billions of dollars on this they have a responsibility to think about activity and exercise within the context of these medical treatments. And we call on them to jump in and help to support this. And we're advocating for that and talking to these pharma companies. But we also have to remember we have a dietary parallel to activity where all this stuff has to happen on the dietary lifestyle side of things. So with that, I'll end with this slide saying, when we think about exercise within the context of these anti-obesity medications, yes, recommend it, but the medications are taking care of the weight loss. Think about activity for everything beyond the weight loss. We have to make sure it's patient-centered, not method-centered. Just because you're a believer in a certain way of exercising doesn't mean that's what's best for that patient at that moment in time. It has to be patient-centered. And if we handle this correctly in our space, in this time that's evolving quickly, our opportunities are humongous. But we have to be integrated and be embracing of the opportunity as opposed to saying it's a them versus us kind of mentality. So with that, I will end and thank you for your time, and I'm happy to take any questions.
If you have any questions, please come to the mic.
Uh-oh, here we go.
Yeah.
Hello, Zacharias Papadakis from Berg University, Miami Shores, Florida. Thank you for an excellent talk. My question is about how these studies and FDA define obesity with BMI or body composition, because if they do with the BMI, I'm assuming that everybody is going to be overweight or obese, and if this is somehow a pointer to the physicians to prescribe more drugs than needed, but if we go down this way and everybody is prescribed these drugs, then we support the notion that obesity is a pandemic. So if we follow down this road again one more time by having the previous example with the COVID that was a pandemic, do you think that these big pharma companies are going to give us this drug for free anytime soon?
They're not going to give the drug for free anytime soon, but there's a lot of fight over the cost of it and who's the payer and all these things. But the whole issue of BMI as a driver of this, it's still one of the better clinical treatments. We can't put everybody on a DEXA to make a decision on this. However, if you read the AMA position, they say use the BMI within the context of the broader scope of health and well-being of that patient. And so it's an indicator, but shouldn't be the sole judger. But one of the things I want to bring up about, And yes, there are the people who have, a high BMI, but have a lot of muscle mass or in great physical condition. But that's a minority. For most people, the BMI is a pretty good indicator that there's something going on. But I want to bring up one other issue that I know can be controversial, but I'll say it. And that is, so many times we've thought about obesity and the BMI on the cardiometabolic health of the patient. And that's true. There are people with high BMIs with good blood pressure, good lipids, will never have a heart attack. But that excess weight, excess adiposity, carried for years, might cause a need for a hip replacement, a knee replacement, low back pain. There's a musculoskeletal side to this whole thing as well. So when we think about excess weight and adiposity, we need to think broadly across the holistic piece. But there is a lot of debate over this, and there are position papers coming out from leading medical organizations and the WHO that are going to be addressing this very, very soon. So pay attention to that. But the pharma companies need to get behind this and help us to make it accessible.
Thank you so much.
Thank you.
That's similar to my question. Are most insurance companies covering this, including Medicare, Medicaid? And if not, if someone doesn't have insurance, what's the cost of these drugs?
Yeah, so right now, older adults, CMS is not currently approved. They're working towards getting approval for older adults. But right now, these medications, for type 2 diabetes, you can get them. They're approved for type 2 diabetes, but not for obesity. One of the medications is now working its way through to get that approval. The cost can range anywhere from $1,000 to $1,500 a month out of pocket. And so there's a pretty high cost to that. That's in the U.S. If you go to Europe, it's a lot cheaper. So there's a bigger problem here. So the cost can be really high, and that's why getting coverage. And right now, like I said at the beginning, there's actually, because of so much use, there's a shortage of these medications as well. So this gets back to ramping up production, making it accessible, making it affordable. All those things are critically important, and that's where the partnership with pharma really has to come in terms of these things. And these medications are not for everyone, but they need to be used for the right intended audience. So,
Thank you.
thanks.
Thank you.
Yeah.
What are some of the adverse health effects of these new medications, specifically for younger adults who may not have other medical conditions?
Yeah, I mean, the biggest things that they're hearing, the biggest ones that come up are mostly nausea and those types of things, which are the most common. There have been some circumstances where there have been some problems with digestive systems, digestive systems kind of shutting down. Those are very rare, but they can happen, and people have to come off those medications. So you hear them, but they're not rampant. When you had some of the ones that were affecting brain, is that you were ending up with people with depression and all kinds of things, the side effects are far less. Every medication has a side effect, but most of them are not very severe. And most of the nausea, what we're finding is that if you match that appropriately with the right eating behavior and dietary counseling and things, you can minimize a lot of that, but you need the right combination of things. Yep.
Thank you.
Yep.
Hey, my name is Shane, exercise science student. I'm at New York Tech. And my question is kind of very long-winded, as any health profession question is. There's a lot going on here. But starting with, do you think the sole, driving of weight loss for genetics, do you think that genetics really influence weight loss or weight gain so significantly? Because
I'm not a geneticist, but if you talk to one of the leading godfathers of genetics of obesity, Claude Bouchard and others, it's a big driver. And I think that, in the same context, let's face it. Our genetic pool it slightly modifies. It takes a long time to change the genes, but over the last 100 years, it probably hasn't changed so dramatically that that's resulted in all the obesity that we're seeing. It's that interaction of our physiology being kind of set up for it, but now us putting the environment over the top of it that's just kind of bringing it to the forefront. So it is that combination of things. But once a person has obesity, it's hard to get them to now lose weight in that environment. And I think that these medications help to level the playing field just a bit. So it's all those things I put up there.
Right. I like how you wrapped in the last 100 years. We haven't had these crazy obesity numbers. I think 2018 it was 30% obese and 40% overweight, which aren't as measures of health. Obesity or overweight. It's not a measure of health. We're not measuring hypertension. We're not doing heart scans.
Right.
But do you really think this is the right approach to take for the world? because we're putting people on drugs that aren't tested in the long term, and our number one oath is do no harm. We don't know how this will affect them, and we're also we're not advertising for this, but we're saying this works as well as exercise. And we know that exercise works, and we know that it's good. And I know the few studies that you brought up was 5 to 10% weight loss with just exercise and lifestyle, and that was a 3-month period. And 10% body weight, or I don't know if it was mass body weight, but that's significant in 3 months. And if they can continue that for the next few months, they'll be at the weight, the healthy weight that BMI says, in a few months.
Yeah, well, I mean, this is a loaded thing, and we can talk all day about this, and so we can come back next year and talk about it some more. You said a couple of really important things. If the person maintains their exercise.
Correct.
If is a big issue.
Adherence, yeah.
If is a big issue. You know, the number of people that start and stop exercise is dramatic. And so we have to think about as our own profession, it's not just about, you know, we have a lot of issues there too in terms of helping people to maintain. You know, yes, these drugs are still in their infancy, but you know, the reality, they've been around for 10 years. And they're constantly undergoing surveillance, and on a regular basis, the FDA has to review the surveillance data for safety. And so that's going to be ongoing. And so if there's a problem, and I'm not saying here this is the solution. By no means am I saying that. Yeah. Don't hear me. I'm saying just like it'd be like saying if a person has hypertension, they're wrong for taking a medication to control their hypertension. Stop it. Why are we doing that? All they need to do is exercise. We don't do that. That is not what we do. A person has diabetes. Don't give them metformin. Don't give them anything. They just should be exercising. We don't do that. Obesity is contributing to a lot of those things. So we need to think about medicine the same way we think, not as the solution, but as part of a comprehensive plan that hopefully gets them to a healthy lifestyle. So don't hear me wrong. It's not the solution. It's part of what we do in medicine, and we need that to be thought about here as well to give people an even playing field. So.
And you think the approach to that will be through a pharmaceutical company and putting these people's lifestyle with the drug? You showed us the graph where when they got off the drug, they gained weight again. And now we're normalizing that. What happens to our obese children that are through the roof?
I think that I'm calling on the pharma companies to jump in and help, but I think it's our whole society has to jump in and help on that. So it's much more comprehensive.
Okay, thank you. Sorry for
that's okay.
long question.
Yeah. Do we have time for any more? We good? Okay. Yeah.
Hello, Doctor. I'm
Hi.
Lizette from Mercy University Exercise Science Program. I had a question. I know that Ozempic is all over social media, and the increase of people using the drug recreationally has made it hard for people who do need it. I'm curious about your studies, what the demographic is, because I know that obesity is just far spread amongst young people. Is there a cap on this drug being used for young people? Is it being encouraged at a certain age? How does it go?
So the drugs, Ozempic is for diabetes, and Wegovy is for obesity.
Right.
These studies have been done on adults, and most adult studies are 18, 21, up to, and they're not really capped at the older adult age, but right now a lot of those drugs are not paid for. Unless you have type 2 diabetes. But there are studies in adolescents where semaglutide is approved for use in young folks as well. But you're bringing up a very good point. The issue of making sure that the drugs go to the right people who really have obesity with chronic conditions that go with that is very different than saying, I just want to lose 10 pounds and give me the drug. That becomes a physician ethical issue, right? And they're not intended for people who just want to lose weight. They're intended for people with the condition of obesity. And so that's another issue. And so we are not advocating as a weight loss for people for cosmetic reasons. This should really be coupled with people who really need it. So that's what we believe in.
Thank you.
Thank you. Hi.
How's it going? My question is just, you were showing the graphs of how people are losing the weight with the meds and the exercise, but do you think there's a way, it was just kind of showing losing, and it kind of plateaued, but does that lead to, if you have a client or a patient that's looking for a specific weight loss goal, is there a way that you think there's to get it to kind of maintain at a certain level instead of constantly losing?
Yeah,
the weight?
eventually these things slow down because you kind of get to that, the
Right.
point where it can't do anymore. But I think that this is the opportunity, and, and God rest his soul, Steve Blair, who we lost last year, he and I had these discussions. Sometimes initiating some weight loss actually helps to make activity and exercise easier. And I think that the studies that we need to do are, do we need, if a person's on, like, say, 2.4 milligrams of semaglutide and they lose weight, maybe they need to stay on semaglutide, but maybe not at 2.4 milligrams, because we've been able to build a lifestyle with that. It's kind of like saying, you get your blood pressure under control with a medication, but maybe you can start to titrate off of that a little bit because your lifestyle's matched up. So we need to do those kind of things. And I think that's the magic here. And I think that those things can be done without the exercise profession involved, or they can be done with the exercise profession involved. And I'm advocating saying, these meds are not going away, so how do we have a seat at the table to make sure that we're handling the exercise piece correctly, which is important. So that, I don't want anybody to mishear me. Lifestyle is the foundation, okay? Sound
Thank
good?
you.
And I want to say one last thing just in general to the audience, and I see Dr. Garber's here, right? I can't tell you what's in it, but we have a consensus paper coming through the American College of Sports Medicine, which is an update to the 2009 position paper on physical activity within the context of obesity care. That paper is going through the process and is almost ready for prime time. You should see it coming shortly. But look at that, because we make some very pointed the points about where the BMI fits, inclusivity of physical activity, these issues around where exercise and activity fit within medication and bariatric surgery. And so it's a much more comprehensive look at this whole picture as opposed to just saying, just do more exercise. So be watching for that in the next few months. Hopefully it'll be out soon.
Thank you. Thank you so much.
Great. Thanks, everyone.